I want to welcome you to our Black History Month celebration of speakers and research and activities and knowledge and expertise at our college. This is an opportunity to share and learn. Let's turn now to our main event and my good friend Wasim, otherwise known as Dr. Wasim Taraf. And I just want to introduce him to all of you. Dr. Wasim Taraf is an associate professor in the Department of Healthcare Sciences and at the Institute of Gerontology at Wayne State University. And he's a proud Wayne Stater through and through. He received his MBA, PhD, and completed 3 years of postdoctoral work in gerontology, all at Wayne State, before joining its faculty in 2013. His research career has been devoted to the analysis of public health data with a particular focus on minority populations, specifically evaluating disparities in health, cognitive function, behaviors, and the use of healthcare among aging, race/ethnic minorities in the US. And that's why we have him here to
I believe it.
talk about health disparities. Since 2013, Wasim has been affiliated as an investigator on the Hispanic Community Health Study of Latinos, also an acronym called SOL, which I like very much, Study of Latinos, SOL, SOL. And that is the largest epidemiological study of diverse Hispanic Latinos in the US. He is an analysis core director for that SOL lab, which is a joint initiative between Wayne State and the University of California, San Diego's Department of Neurosciences. He is also very noteworthy, I would say, a site PI and lead statistician on 5 NIA-funded R01s. Really terrific. And these research studies are all focused on the biopsychosocial risks for cognitive and brain aging and Alzheimer's disease and related dementias among Latinos. He's particularly proud of his role and leadership on 2 multi-institutional NIA-funded research centers for minority aging research in Michigan. And he is an analysis co-lead in all of this, again, all focused almost predominantly on Alzheimer's disease and dementias. What's so important here too, and what I really appreciate about Wasim, amongst many other things, is his commitment and dedication to the training and mentoring of the next generation of postdocs and junior faculty working on minority health. And his commitment to diversity in research and research in aging is most welcome and most appropriate at this time. We are really lucky. He's a national and international expert on minority aging, and we've got a foot, or at least a foot and a half of Wasim in our hallways. And it's a real pleasure, Wasim, to welcome you here to talk about your work. And I will just turn that over to you.
Thank you so much, Kathy, for this nice introduction. Last year, you're confused. I wrote it, so I'm trying to pump myself up so that I sound like I am someone important. I am really, all I do is enjoy the research that I do, and Wayne State has provided me, and the college has provided me with a wonderful home to do the things that I enjoy. So thank you so much for taking time on this cold Friday afternoon to listen to what I have to say. What I want to hopefully accomplish in the next half hour or 45 minutes or hour that we have together is just to show you some statistics related to disparities, to try to potentially contextualize what I mean when I do the work that I do as it relates to that concept. And so just a bunch of slides related to the definition of disparities and the implications of that. And then after this, I want to take a little bit of time to show you some results from an ongoing project that I have with Peter Lichtenberg, who is the director of the Institute of Gerontology, a project that is funded by the American Psychological Association to look at the mental health um, impact of COVID-19 on minority populations. So I have a few, at least I think, interesting slides just that highlight how this pandemic has affected us as a nation, and try to drive the point home by showing you what counterfactuals, right? A world that does not include diversity, what does that mean? What kind of factors do we have to work on so that we can achieve such a world? So I'm going to share my slides here, and I don't want to talk for 45 minutes or half an hour, or what have you. So if you feel like you want to jump in and tell me, this doesn't make sense, or this is interesting, or I disagree with you, or what have you, then just jump in, and I'm more than happy to learn from you through this process. Okay, so I'm going to share my screen now. Go from the top here. This is me, and the talk was titled "Disparities in Health and Healthcare Among Older Americans," but it's actually it starts by talking about Americans in general, and then zeroes in on older Americans, so that I can show you the work that I've been doing. I think that the first thing that potentially we can do is come up with an agreement about the meaning of the world disparities. Finding a common definition, obviously in science, can help solving problems, because if we're talking about separate things, then potentially we're trying to research different constructs. I find that when I give these talks, people always, to some extent, confuse disparities with vague terms, like grand but vague terms like justice, like fairness, like equity. These are things that are laudable as concepts, but they mean potentially something different than disparities. Disparities is interesting to me, because if you follow the definition, then you can potentially come up with a way to measure it. And if you can measure it, then you can solve it. So disparities in the sense is just a difference between two groups, and that difference has to be systematic, it has to be replicable, it has to be ongoing, and it has to be negative. And the negative side of it is usually on the less advantaged group. And so when you compare a less advantaged group to a more advantaged group, whether that's race, ethnic groupings, whether it's income groupings, whether it's sexual orientation groups, what have you, if you have a negative on one side and a positive on one side, then you have the propensity to have a disparity. But that's not the end of it. A disparity is created by a social system, and it can only be addressed by the social system itself. And I'm going to try, again, this is at least today, the most important point that I want to drive, is that it is really social determinants of health that form the primary backbone of what leads to these differences between groups. And disparities, for them to happen, they have to be not personal choices. They can't be preferences, and they can't be needs based. And I'm going to clarify this as I move forward. So what do I mean by disparities? When I say systematic and happening over time, it means that things haven't changed. People confuse progress with reduction in disparities. Just because we're moving towards a better outcome as a nation, and all groups are moving towards that better outcome, does not mean that we have a reduction in disparities. A disparity is a difference. So if all groups are moving in the right direction, and yet the differences between the groups are maintained, then we continue to have disparities. Unfortunately, since disparities became something that we're interested in researching and solving in the early 1980s, we have made very little progress in terms of addressing it. This plot is intended to show you some at least disheartening results about quality of care. So this is these are statistics that are generated by the federal government that follow 58 measures of quality of care. This includes things like person-centered care, care coordination, patient safety, care affordability, treatment effectiveness, and so on and so forth. And what you see is that since this stuff has been tracked in the early 2000s, nothing has changed. So we're moving in the right direction, but we're not able to close the gaps that exist between these groups. The second point that I want to drive is that disparities are not disparities in outcomes, but they're also disparities in the workforce. And this is something that we as a college talk about a lot, and as a university talk about a lot. So through this slide, I just want to show differences between population share and healthcare workforce share. And the points to emphasize that, I put three things here that might be interesting to the attendees today: physicians, pharmacists, and therapists. And you see a great gap between potentially what should the share of these individuals be in the workforce compared to what their share in the population is. So if you look at the first graph, you see that about 30%, a third of the population is Black or Hispanic. The share of physicians in the population is 11%. For pharmacists, it's more disheartening. Again, a third of the population is Black or Hispanic, and only 7% of the pharmacist population is of these two backgrounds. And for us OTs and PTs, a third of the population is Black or Hispanic, and we only have about 9% that's either, this is actually exaggerating because that 2% is more than one race. It's not actually Hispanics. So only about 7% of the population is actually of these two racial and ethnic backgrounds. All right, so we have disparities in outcomes, at least quality outcomes. We have disparities in workforce distribution, and these things have an actual impact. They have an impact on morbidity. They have impact on treatment efficacy and on mortality. These are things that we have not been able to solve. So today, if you do a major survey, population health survey, what you'll see is Blacks and Hispanics are 1.5 or two times more likely than their white counterparts to have hypertension and diabetes. That is a problem. That is something that we have to take care of. We have disparities in treatment efficacy. This is something that I like to highlight because that shows that we're not treating people appropriately. We're making progress, but that progress is a relatively slow progress. So for individuals that have diabetes, the prevalence of individuals with end-stage renal disease used to be 5 times as high in Blacks compared to whites and 4 times as high in Hispanics compared to whites. We've been able to reduce that to about 3.5 and 2.5 folds, but that's still a problem. This is where really a lot of focus has happened over time, and it's mortality, loss in unnecessary loss in life. Again, we've been able to make some progress, whereas in the 1970s, the differential life expectancy between Black males and white females was about 16 years. Today, it's about 9.5 to 10 years. So all this is to show you that disparities are real when you look at the actual statistics. The problem is our recognition of disparities is not where it should be. This is a paper that was published a few years ago asking primary care physicians about their opinion on care provided to their patients, if they think there are disparities in the care provided to their own patients. And what you see here is when you look at the macro level, right, physicians assessing whether there is a disparity at the system level, almost everybody, 90% of these people say, these physicians say, yes, we have a problem. When you narrow the question to have it focused on their own health system, that shrinks to about 30% and 35% of people saying, yes, we have a problem. There are disparities problem. When you ask them about their own patients, that drops down to about 25 to 30%. And these are primary care physicians. So these are people with big hearts. If you ask these same questions of cardiologists, the study came out about this, about a decade ago now, an astonishing 5% of cardiologists think that their treatment of patients does not include any kind of disparity. So you have a reality where the statistics kind of point to very obvious and large differences between these groups. And you have another reality that exists among care providers that point in a completely different direction. These realities collided recently in light of the pandemic that we have. So now everybody's forced to think about these major differences that exists in hospitalizations as a result of COVID-19. And if you look at this graph, this is a most recent graph from the CDC. It shows that hospitalization rates of, this is age-adjusted hospitalization rates across groups, is 4 times as high for Hispanics and American Indians and Alaska Natives, about 3.5 folds for Blacks compared to non-Hispanic whites. This is not just a hospitalization issue. This is also a death issue. This is a graph that really drives the point home. And what you see here on the slide is a difference between the death share in the population versus the population share. So this is how many, the prevalence of people that are dying minus what their population share looks like. And what you see here is in Latinos and Blacks, they're dying at a much higher share than their population requires. Now, here's the tragedy of this plot, is that the death is happening really among the young individuals, not among the old individuals. So in terms of, if you want to put it in a crass way, in terms of human and capital loss, this is a major issue for the nation. All right, so in light of all this, what we wanted to do with the APA through this project is try to assess the impact that COVID-19 has had on the mental health and well-being of diverse older adults. The project with the APA includes Asians. I just excluded them from these sets of slides as to just streamline the presentation. But what we wanted to accomplish is a few things. One, assess how deep the problem is. What is the prevalence of these psychological problems that exist among older adults, 50 years and older? We wanted to see if things are changing over time. Are they getting worse? Are they getting better? Are they improving, then getting back up? We also wanted to see what are the main drivers of differences that exist between these groups. And this is where I want to point to the social determinants of health as major problems that are driving these differences between the different populations. And then we wanted to look at whether there are certain things, in particular, social connectedness issues that provide a layer of resilience for older adults, and whether that layer of resilience is differentially distributed in the population for whites, Blacks, Hispanics, and Asians. There are several things that we considered in terms of covariates and constructs to try to test these relationships. I'll come to this later, but this shows you what I mean by social determinants of health. I mean economic stability, neighborhood environment related issues, education, basic needs such as food, community and social connectedness, and then availability of access to the healthcare system, to a quality healthcare system. The health outcome, of course, in this case, the one that we were focusing on is depression, anxiety and depression. So to do so, we were lucky enough to have access to a major source of data collected by the Census Bureau. The one thing that I like about this data is that it's in data terms, it is relatively instantaneous. So what the census decided to do, to just keep a pulse on what's happening in the nation, is to collect data on about 100,000 people every 2 weeks and then release it directly to investigators, make it publicly available to investigators so that they can study how things are happening and changing at a faster rate than we usually do in academia. So what we did is we collected this data from April to December of 2019. So that's about 15 biweekly points, which amounted to about 2 million observations. That's a relatively substantial number of individuals that were included in the analyses. Since we were mostly interested in this particular study in the 50 plus population, that reduced the sample size to about 1 million. Now, 1 million, that's not a bad number. I tell you, you can get a lot of power out of 1 million observations. So over the next few slides, I'm going to show you what we found out based on these collected and analyzed data. Again, we looked at general health status as well as anxiety and depression, so well-being and psychological outcomes. Because this is a kind of a brief survey that was done with the census. They didn't do kind of a deep investigation or deep collection of data related to anxiety and depression, but they used instruments that are accepted in the literature. So for anxiety, they have two probes, 2 questions relating to feeling nervous, anxious, or on edge, and not being able to stop or control worrying. These are measured on a 0 to 3 scale, where 0 is not at all, and then 3 is every day. Same thing with depression, 2 questions, one on pleasure and interest, and the other on feeling down. Again, these are accepted measures. We followed standard definition, looked at depression and anxiety separately, but also looked at the combined measure of depression and anxiety. If a person scores on these 2 different instruments, 3 or more, then they're considered to have an elevated level of depression or anxiety. And these are the slides that I'm going to show you. These are the results that I'm going to show you next. We controlled for a whole bunch of factors that correspond with these social determinants of health to try to pinpoint what exactly is causing elevation or attenuation in prevalence of psychological problems. So for demographic factors, we included age, gender, marital status, living alone, having children below 18, living in the household. For health enabling factors, we looked at education and income, employment stability. So we looked at household job losses and expectations of losses. And then a bunch of indicators related to healthcare access. So whether they've been able to access care, what they have insurance, they don't have insurance, what kind of insurance they have. And then reported access to healthcare independent of COVID. This one is the particularly interesting one that going into this, we didn't think was going to be a big deal, but it ended up being the real story, and that's basic needs. So they had questions about having enough food, and then having confidence in food sufficiency. And those ended up, as I mentioned just a second ago, being the real story. So in terms of prevalence of these psychological problems, we were really, really shocked by those elevated levels. And 2 in 5 Hispanics, for example, report elevated levels of depression or anxiety. About 1/3 of non-Hispanic Blacks, the numbers, the prevalence is still elevated in whites as well. And what you see on the screen here is the national prevalence and then the prevalence in the state of Michigan, and they're relatively comparable. So Michigan kind of tracks with the nation. I'm going to come back to this point in a little bit to show you that when you talk about disparities, it's very, very important to contextualize what you're talking about. Different states have different policies. They have different levels of the safety net, so on and so forth. So that ends up being a major issue for these populations that we're looking at. Okay, so how did things change over time? Well, this was surprising to us. We thought that it would be more of a linear trend. So the more you move on in terms of time, the higher the prevalence would be. But what we ended up finding is that there's a curvilinear. So what we noticed is that the prevalence increased in the early stage of the pandemic. Then around the summertime, when there was talk about potentially having vaccines, schools not being major issues, a little bit of relaxation in terms of people being able to go outside the home, so on and so forth, you see kind of a relenting of that prevalence, remaining high, but relenting nonetheless. And then towards the end of the summer, you start to see again a pickup, and that pickup becomes particularly pronounced in the Black population. So that's the yellow line that you see right here, an increase into the mid summer, a decrease, a slight decrease, then again, a major pickup after that. So the rates remain, the differences between the groups remain. And then as we move in time, the prevalence for the Black subgroup kind of almost became as equal as that of the Hispanic subgroup. So these trends were particularly evident in Blacks and Hispanics. You see a more linear trend in the white group that we looked at. Another surprising thing that we found is that age is actually a factor of resilience. So the older you are, unlike what a lot of people expect, the older you are, the more resilient you become. And this is true across groups, differentially so in terms of the slope that we found. So older whites in particular have a very low level of anxiety or depression compared to, let's say, older Hispanics. But across the three groups, the older you get, the less likely you are to report anxiety or depression. So this was actually a positive outcome, particularly for Peter Lichtenberg, whose mission in life is to show or argue that older adults are not as frail as we think they are. They actually have a certain level of resilience that they develop over time, and in many instances, they have much better outcomes compared to middle-aged adults or even younger adults in this particular case. All right, so this is, I think, the most exciting slide that I have. It is terrible news, but it's exciting in terms of research findings. Remember that the average prevalence was about 35% for anxiety and depression combined. Now, if you look at individuals that reported not having enough food post and pre-COVID, and those that have no confidence or low confidence in food sufficiency, those numbers are around 70% for the first two and about 55% for the third. So the people that are impacted the most by this pandemic are the truly vulnerable people in the population. And these results are consistent across all three groups. Now, here's where the disparity story comes in. All these factors are equally prevalent across all three groups, right? In terms of leading to higher levels of anxiety and depression. The problem is the unequal distribution of these factors across these groups. So whereas 4% of older white adults report not having enough food pre-COVID, that number is 3 times as high among Blacks and almost 4 times as high among Hispanics. If you look at any of these factors on the list, you see that trend is maintained independent of how you look at it. It is this differential really that we think is creating these social determinants are where driving some of these major differences in groups that we find. All right, so here we try to better test this, so model this, and people start rolling their eyes here or say, I'm less interested in this. This is a statistical technique that we use, which is called variance decomposition, or difference decomposition. So what this does is it basically looks at differences in prevalence between two groups. Let's look at column 1, Blacks versus whites. The difference is about 5.6%. And then you ask yourself the counterfactual question: what if we were to make the distribution of all the factors that we're going to include in the model equal between these two groups? What if we made the whites and the Blacks look exactly the same across these different sets of factors? What would happen then? So what you see in the lower part of this table is what would happen if you made the two groups equal. And what would happen is the following. You would shrink the differences, and you would shrink them in a way whereas the Black population becomes more advantaged compared to whites if they had those same, if they had an equal distribution of these factors across the two populations. So in reality, the difference between blacks and whites is 5.6%. The prevalence of anxiety and depression in blacks is higher than whites. If you were to make all these other factors equal across the population, then blacks would have a 5.8 advantage in terms of they'd be much less likely to report anxiety or depression. That number is how much higher, almost double in terms of difference between Hispanics and whites, 11.5%. Again, if you were to make these factors equally distributed in the population through the counterfactual, then you reduce that to an advantage for Hispanics over whites that's equal to about 1%. So that's one part of the what we wanted to accomplish through this. The other part was to try to see what is driving those differences. And if you look at these percentages here, what you'll notice is that basic need factors, the 5 different elements that I talked about before, not having enough food pre-COVID and post-COVID, not having a good level of income, worrying about food sufficiency in the household, these things account for about 40%, and this is equally so across blacks and Hispanics relative to whites. 40% of the difference is the result of these inequitable distributions in basic needs across the two populations. The other is coming from health factors and some of the demographic issues. We have a more detailed table that kind of pinpoints in particular what in these different kind of sets of factors explain those differences, but I'm not going to include this here. The last thing that we wanted to see is whether these kind of psychological measures of resilience, trust, being part of a community, talking to neighbors, connecting to family and friends, and so on and so forth, has an impact on reducing these differentials that exist between the group. And what we noticed was surprising here. This is based on a different data set. This is based on data sets that were collected by the University of Chicago. But what we noticed here is that these, at least at this point in time, are not playing as big of a role in levels of anxiety and depression as we thought they would. Now, the mechanisms for why this is not happening, we don't know that yet. We're still thinking it through. But that was also another interesting and unexpected result that we found. So to bring the point back home, if you think that social determinants of health play a critical role in health outcomes, then our hypotheses, as this data shows, are in fact supported. Economic instability, lack of educational attainment, basic needs such as food play very important roles in balancing these differences that exist between the groups. We did not have enough measures for neighborhood and physical environment to account for that, so this was out. But we didn't find enough evidence to support community and social context playing a role. And then healthcare system, so access to the healthcare system, access to insurance, access to a healthcare provider did not play as big a role as we expected it to play through this data.
Thanks. I greatly enjoyed the study and seeing all the different variables and parameters and finding other people who believe in the importance of social determinants of health. You know, one of the challenges of doing these population studies is controlling for the world we live in. And so although you're looking at the impact of COVID-19, this year has had such tremendous other issues, such as the death of George Floyd, the election protests, and other things that directly influence anxiety and depression. So how are you going to account for those things in your research?
So that's a great question. Thank you. I think you should also talk to the APA people because they're pressing us on that point. In a perfect world, what we would have is a pre-post where we can control for things prior to these events and potentially see if through that control we can explain some of these differences. In reality, the answer is we probably can't get that through the data. Now, one thing that we are planning on doing, so what I showed you here is national level estimates, with the except of the slide that shows Michigan. One thing that we are planning on doing is disaggregating, stratifying by states, and then potentially linking specific events that happen to in certain states to spikes in these outcomes and the prevalence of these outcomes. So if in fact 2 adjacent states, right, or 3 adjacent states, one of them having a major event such as police brutality in the example that you've given, that potentially what you can see is a more elevated, a bigger spike happening in that state compared to the other states. Now, these are national conversations, so potentially they're going to have a simultaneous impact on multiple states, but at least we can tease out if they're having a much bigger impact following an event in that particular locale, compared to kind of some control states that we can come up with. So that's one way by which we can control for these localized events. Now, I think the bigger challenge for us is that state policies are not a constant. Different states intervened in different ways. This is potentially, if we're looking at national data, this is potentially a major source of error for us. I don't know if I emphasized this slide. I don't think I did, but I'm going to go back to it to just show you what I mean by this. What you see here on this slide is a much wider variation. So the first thing is that groups are different, right? Average whites are different than average blacks, are different than average Hispanics. But not all Hispanics are the same, and not all blacks are the same. Whites tend to kind of be closer together across the states compared to these other groups. So what we want to see is whether we can explain these variations, geographic variations that exist between these groups through potentially accounting for state policies, including what you have correctly pointed to, which is certain events happened that could have led to these to increase in prevalence within certain states or certain locales. Okay, this is a long answer to that could be kind of stated differently. You're right, we can't control for that. We have to wait for more data, and what we're planning on doing is when more federal data becomes available, we're going to go back in time, look at the BRFS, for example, which is a surveillance data set, see what was happening through the BRFS up until 2020, see if things have changed in 2020 and what they came back to in 2021, 2022, and so on and so forth. So we can potentially isolate those issues if we can see kind of a decline over time.
Well, and probably the social determinants of health are influencing all those things as well. So, focusing on SDOHs is still the way to go, and to try to get more policy and even healthcare providers to understand the importance of these things in our training and in our provision of care. So thanks for all your research.
Thank you.
Wasim, I want to jump in if I can with the set of students and faculty who care about all these issues. I wonder if you could share a few reflections from your experience in research on social determinants of health, which is a vast amount of experience, and then speak to how faculty or people who are concerned to share this science and translate it into meaningful improvements in clinical practice. I have always thought for many years, as I've taught research or anything, there's when students are young and inexperienced, they're so focused on the illness, the disability, and the technical treatment and delivery of quality care as they conceive of it, I think it's hard to convey the context and the depth and the accumulation over a lifetime of small disadvantages. You're pointing out some big disadvantages when you point to food security, but I'm thinking of a safe neighborhood as a kid, or an opportunity to advance your education, or reliable bus service. And so when you have that novice clinician trying to do a good job and being mindful of these differences, how do you make that translation and connection in the classroom to enhance what we all need to be doing more of at the college, which is appreciating the impact of these life forces, social forces, on the end point, which is someone being sicker and having less than we would expect them to have as white clinicians. So I'm just curious how you confront that.
These are excellent.
The data.
These are excellent points, Kathy. One thing that I should have mentioned but didn't mention is that research on disparities went through 3 phases. One was exploratory, trying to showcase that disparities do exist. 2, trying to look at the sources of those disparities. And those are, pretty well established literature. The third, which is directly related to your point, is solving disparities. And that's where we have been stuck as researchers and practitioners for a very long period of time. We have been stuck primarily because of what you just said, which is trying to find grand solutions. Whereas really the solution is at the individual level, training and making clinicians, the future clinicians, more aware of these issues so that they can intervene at an individual level and build on that. That increment is very critical. Doing large scale interventions, making them feasible, making them scalable. What we've come to realize over time, this is very, very hard to do. It requires a lot of resources. And in many instances, you don't have the kind of the attention span of the funding institutions so that you can follow through on these major needs. So it ends up being exactly what you're saying. Convincing the practitioners, convincing the therapists, convincing the physicians, convincing the pharmacists that they are the day-to-day buffer against, maintaining those disparities that we have, and that kind of these individual conversations that they have, being aware of things outside of this patient is sick, this patient is not sick, that this patient exists within a context, and you have to address the context at the same time as addressing the clinical needs of the patients. Now, how to do so, I think starting the conversation is potentially the best way to do it. So in my class, I teach a research methods class in the college. These are the kinds of conversations that I try to engage the students in that, yes, you are clinicians. Potentially your job is to create a treatment to these patients, but these treatments are not necessarily just treatments for whatever the ailment is. These treatments are for something potentially bigger than what you're seeing in front of you. And I think you're an OT, and I'm nested in the OT. I think having a holistic approach, which I love, is definitely the way to go. So I think OTs have, to some extent, an advantage over other professions. I think PTs potentially as well.
Wasim, I wholeheartedly agree, and I'm sure a lot of people on the call would too. And yet, as I get older and as I see years upon years of some of your early slides around how slow that progress is, I've just got to say that the force of public advocacy and activism you know what, maybe that's what we got to do. You know, chipping away at it one person at a time, one patient, it's absolutely. But I kind of think of it sometimes like seatbelt legislation. You know, if you just make it a law and you get a pricey ticket if you don't do it, then we have changes in public health. And, you know, even with the Black Lives Matter movement itself, we've all been talking about these topics, diversity, inclusion, climate, forever. But there's these moments in historical time that it's like you've got to not waste it because, like you said, you know, we've got the politician's ear or the corporate ear. And I just wish I knew how to connect those dots and fully take advantage of that. Sometimes I think it's like marching in the streets is the way you've got to do it. It's not quite enough to do it only in the classroom. So I don't know. I think I read a lot about those raging grannies who get out on the street and make things happen. They get attention, they get media, they get you know, the ball rolling. So I'm on a tangent here, I'll stop, but I'm interested in the force of political action too.
Yeah,
There's
I wish I had the magic wand that can make this happen. These conversations and the movement across time is very, very incremental and frustrating. You know, we're making progress, but in my opinion, not enough progress. But I think the first step is to start and make these conversations fundamental to the way we approach the practice. Right? These are not just things that should go on slides. These are things that should inform the way people engage with their patients. And I think if we can get to that level, I mean, those statistics about physicians and cardiologists, not to dump on the physicians, but you know, it's a problem as long as it's not my problem. That kind of mentality is a major problem, and overcoming that is, at least in my opinion, a first step towards creating a better solution.
I have been recently very much interested in telehealth, and I was wondering what your opinion and your input would be on the effect of telehealth on health disparity.
I think it's exciting. It's the future. And the pandemic is making this you know, a reality that rather than something that, oh, this is going to happen next. So a lot of treatments now are going through these methods. Okay, so this is my opinion as a layman. My opinion as a researcher is I have not seen really any clinical trials that indicate to me that these mechanisms, right, are potentially capable of reducing disparities for many reasons, you know, that I'm not going to go into. But in most instances, you see these RCTs kind of focused on a specific thing, like pain or like reducing anxiety or you know, these kinds of things. Now, are they scalable is the question that I always ask myself. You know, so you might see some evidence of improvement when you focus on a specific domain. But when you try to take that to a much larger context, I think then we have a problem. But again, since COVID now is created a new reality where these things are, you know, the norm rather than deviations from the norm. I think we have to wait for a couple of years to see if this forced revolution, if you will, in terms of how providers deal with patients, if that's going to have an impact. You know, we'll have to see. A lot of people on this call are the clinicians. I'm not a clinician. I sit behind a computer all day and look at data. So I think the first line of argument should be you guys. Are you in fact seeing that this is having an impact on the way that you deal with your patients, that you connect with your patients, that you talk with your patients, that you solve your patients' problems. Is it leading to more instantaneous and more gratifying result for you and your patient? I think that's something that I'm interested in hearing about, rather than, oh, has this RCT been done? Has it been able to reduce the differences that exist between these groups by a couple of percentage points?
I think this is a very rich area for learning, growing in that field, and doing research. I think it's so novel, and we are learning as we are implementing, really. So, keeping the thoughts of these outcomes in mind of, will it improve the disparity differences? Will it improve outcomes of the patients? Are things that we're going to hear about in the near future as telehealth gains momentum, like we've seen over the last year. So I hope we can collaborate on that.
Dr. Doreen Head, I need to put you on the spot, and I'm doing this with no warning to you, Dee, but you are born and bred in the city of Detroit. You've been practicing in the community for years and years. You care about all of this a lot. You know it. Do you see improvement? Do you see better understanding, or what's your take?
Well, thank you, Kathy, for putting me on the spot. I appreciate it. I had my hand up actually because I had a few comments. I think it's important that we make students all aware of what you said, Kathy, was that the context, the environment is something that's very important that we all should be focusing in on in our teaching. And that's key to OT as part of our domain. But I think it's important that they understand the health disparities and how it affects different groups. And as clinicians, it's going to be very important. And dissemination of the information that Wasim had is very important, because one thing that COVID did was put a spotlight on the disparities, especially even in my neighborhood. I live near Sinai Grace Hospital, and this is an area where people are underserved, and those basic needs are not being met. And so, it really, your research informs policy, so money and dollars can be put in those areas. So yeah, the spotlight was on, money was flowing. And what I think is really important, and when we look at our community, is how our faith-based and church groups come together. And even today, when I was coming back from the job, I passed by a church with the signs, free food. I mean, through the summer, I was getting boxes of potatoes and tomatoes, and and so to address those basic needs, our community groups come together. But if people don't know that there's a need, then people aren't going to come together to do those things. And so your research is very important to affect the environment, the context in where we live. And we know there's always going to be disparities because of education and class, and but we want to close those gaps. And being a native Detroiter, yes, I've seen it. And I've, on one side of the city where people have the haves and the have-nots, if you will, and then the people who have the twos and fews, but we're all trying to live, and have those same basic needs met. So I think what you're doing, Wasim, is so important, but we have to find ways to disseminate that information to the people who had money. Those are my thoughts. Thank you.
I had a question about objective measures. I know that, it's a big, focus area to have biomarkers that can objectively tell us if, we could really measure anxiety, depression, stress, and things like that. We had former colleagues in the OT program who were measuring cortisol levels from hair samples in the local population. Might you have access to such objective data to compare with your self-reported data?
I wish I did, Roche, but Sam Zaloli, Sam Z. I don't know if you know Sam. He's in psychology and iBio. He's got an ongoing longitudinal study of Detroit residents, and he's been collecting cortisol hair cortisol and I think saliva-based cortisol on these individuals. So it's not a million people, and that's the thing. Can we get that kind of data on a million people? I think I'm doubtful. But you'd be surprised at how much you can get out of 300-400 well characterized, as you say, individuals. So linking that, contextualizing that with kind of subjective measures and social determinants of health type things is definitely the way to go. Yeah, I'm not. I got to be honest. I'm not a stress person, and I'm not a psychologist, and I don't study mental health. I study something quite different. This was a great distraction for me, this project working with Peter, and it just came as an opportunity. But just to kind of circle back to what you said, Roche, which is biomarkers provide better instruments for measurement than self-report. Yeah, back in 2000.
I didn't say
You
that.
didn't say that.
I was saying that there is an emphasis to
Exactly.
try to use objective biomarkers. I'm talking more from the NIH standpoint. They're so desperate to get biomarkers that can tell if a muscular dystrophy is progressing or if it's static. Yeah.
I'm going to tell you my story about biomarkers. Up until 2015, most of the data that I dealt with was actually kind of self-reported instruments through surveys. And I always wanted to get biomarkers. I always wanted to get blood samples. I wanted to get saliva. I wanted to work with these. I wanted to work with MRI. I used to focus on survey collected cognitive function as, the way to go. And then we got brain imaging and we got kind of fluid biomarkers and all that stuff. And I thought we'd get a lot more precision through these things. And I was so disappointed when this didn't happen. And I realized that, the same problems with bias and reliability that you get from subjective measures are also things that you have to deal with when you're dealing with these things. In fact, it's potentially sometimes more problematic to deal with those, just to control across different collection mechanisms than it is to do it for survey-based data. But I think you're right. The NIH now is pushing towards having both, the richness of the subjective and the characterization through the biomarkers as the model to go. So just being in one space is not sufficient anymore.
But with the time, I want to draw it to a close now. Thank Waseem Taraf very much for sharing a tiny sliver of a great deal of work that he does so very capably at the college and on this campus. We're lucky to have you, Waseem, and I thank you again for sharing as part of this Black History Month. Thank you all for tuning in. Have a great weekend, and we will see you all soon.